evening, everyone. We'll just give it a couple of minutes for people to come in. There's the numbers are streaming in at the moment. Give it a few minutes and then we'll get started. So this evening will be on physiology, continuing from what we covered on Monday. So for those of you who were here on Monday, we covered some physiology questions, some of the common, what we believe, high yield questions that cover areas that hopefully you should be studying, revising, and then going through these questions and trying to consolidate the things that you have been learning. I have included into this presentation and some of the questions, a few perioperative care type questions too, but we will tackle them as we do. So I'll give it another minute to see if anybody else joins and then we'll crack on. Again, if anybody has any questions, put them in the chat or the Q&A. We'll screen them as we go along. And then again, at the end, I'll be happy to take any general questions. Can be anything about the exam or any other stuff. I'd be happy to try and answer it as best as I can. Okay, so I'll give it 30 more seconds. And again, the format of this session, for those of you who are new, those who have been tuning into other lectures or webinars of this series, welcome back. The aim of this isn't necessarily to impart and teach theory, because obviously I think, you know, that's going to be something you're going to be doing anyway in preparation for the exam. What we aim to do is just go through questions, drilling questions, common questions that often come up in the exam, key core areas of topics. So we'll have a poll, answer it the best you can. There's no pressure. You know, don't worry if you don't know at this stage where you guys were this far out from the exam. There were a lot of things that, you know, people who have sat the exam successfully, you know, we're still working on a lot. So don't worry, don't get too downhearted if you don't know things, and try to use this as a good resource. Okay, so why don't we get started? Okay, so if we start the poll for this question, thank you. Which of the following is not correct regarding cardiac action potentials? Okay, so you've got the options there in front of you. Have a good read. And we'll go through it. Which of the following is not correct regarding cardiac action potentials? Okay, almost half of you have voted so far. We'll give it another roughly 15 to 20 seconds on this question. Okay, 3/4 of you have voted. A few more seconds. All right, let's stop it there. Thanks. Okay, so looking at the answer, about 43% of you that voted went for E. The parasympathetic nervous system affects heart rate in a transplanted heart. And that would be correct for those of you who answered that. So well done. Cardiac action potentials, the cardiac cycle, essentially, didn't come up all often. It would be maybe one question if it did as part of the physiology, but it's something just to be familiar about. If you go through this, and I'll just pop it onto this slide here, great. This is obviously the cardiac cycle in terms of the action potential being generated. And so you have different phases, and it's worth just getting familiar with the different phases, because sometimes the way that they may phrase the question is relating to each phase. So it may say phase 2 is X, or X happens in phase 2, or does this happen in phase 3 or 4, for example. So phase 0 is your actual depolarization. That's the rapid influx from a resting membrane potential of about minus 90 millivolts to depolarize, and that's because of sodium channels being open. Okay, and if we go back here, that was the answer to D. Rapid depolarization is caused by increased permeability to sodium. And of course, looking at that, that has to be correct. Okay, we've seen it here from this cardiac cycle. Now, leading on from there, in phase 1, you have a small portion of rapid repolarization. That's the initial repolarization. And that's because you get a small increase in potassium permeability. And again, that's essentially what we're referring to in B. Rapid repolarization occurs due to increased potassium permeability. Okay, so that is also true. Now C, calcium influx is responsible for the plateau in the cardiac cycle. Now, of course, that plateau is to allow time in between depolarizing action potentials to allow the heart to essentially fill up between, diastole and systole. So essentially, that's phase 2, where you've got that plateau, and that is caused by calcium influx. And then again, obviously, 3 and 4. 3 is that rapid repolarization. Okay, when calcium channels shut, and then you go back to that resting potential. So just because it's phase 0, that doesn't mean that is resting. Okay, in the cardiac cycle, phase 0 is depolarization. Okay, and then the reason why E is incorrect is because in a transplanted heart, it's denervated. Okay, the nerve supply to the heart has been cut when you've removed the heart from the donor, and transplanting it in the parasympathetic or sympathetic nervous system won't be able to act on the new heart. Hormonal effects can happen, but in terms of your fight or flight response, it won't, the heart won't respond normally. So that's something that you counsel patients in after a heart transplant. So let's move on from that. The next question: what is true regarding the mechanism of furosemide? Okay. Again, 5 options to choose from. Have a read through them. So we're thinking about furosemide and its mechanism of action. And what is true of these options? Okay. Give it about another 30 seconds. Just more than half of you have voted already, which is good. Give it about 5 more seconds for any last voters. Okay, let's stop there. Perfect, thank you. So, 57% of you who voted went for C, inhibition of sodium, potassium, and chloride channel in the ascending limb of loop of Henle. So that would be correct. So let's have a look at why. All right. Now, mechanism of diuretics and where they act may come up. I'm not sure why, but they often ask about loop diuretics. So obviously furosemide is an example of that. And so just be familiar that furosemide or loop diuretics act on sodium, potassium, and chloride channels in the ascending limb of the loop of Henle. And this here from the example, loop diuretics is number 3. And you can see from here, it's acting in the ascending limb. And the ion channel that it affects is a sodium, potassium, and chloride channel. All right. So that's where the loop diuretics will affect. Okay. Obviously, look at the other options and, make yourselves familiar with the different options of diuretics that are involved, your thiazides, potassium sparing, such as spironolactone, etc., and where they act and what type of channels they affect. Okay. So, which of the following statements regarding metaplasia is not true? Okay. So, which of these statements is not true in regards to metaplasia? Okay, I'll give it about another 10 seconds. About 2/3 of you guys have voted so far. All right. Let's stop it there. Great, thank you. So, a bit of a mixed, varied response to this question. Majority of you who voted went for D. Metaplasia is characterized by abnormal mitosis, pleomorphism, and high nuclear cytoplasmic ratio. And then there were a few who went, and it was spread fairly evenly across the other options. Now, definitions to things like metaplasia, dysplasia, is something you should just be really familiar with, and then know and understand what happens in each process. Okay, so the answer to this question is D, and we can go through why. First of all, why don't we go to this slide, because this breaks down essentially the differences between metaplasia and dysplasia. Okay, metaplasia, and I'm sure obviously a very common example that you could use is in the esophagus, where you have reflux of enough gastric acid that causes insult, and that will essentially start changing one mature cell type to another, and that is metaplasia. You get conversion of mature differentiated cell into another form. Okay, and so clearly there is a conversion that happens. It can obviously happen in different types of tissue. And another thing to remember with metaplasia is that it's reversible. Okay, so take away that insult or stimuli and it will slowly reverse. And also metaplasia does not lead to, so it does not lead to the formation of cancers. Okay, now dysplasia on the other hand may cause cancer, so it can be seen as precancerous, and a common example of that is ductal carcinoma in situ or cervical cancer. You get development of abnormal cells within a tissue, but It's that mature cell that changes its phenotype. And often you get certain characteristics of malignancy that slowly start to creep in. And that is what essentially Dee was talking about. And this is an irreversible process. And so you may get, for example, abnormal mitosis that happens, and that's a typical sign of malignancy. Pleomorphism, and so you have lots of different types of cell shapes. And then again, high nuclear to cytoplasmic ratio can also happen in dysplasia. So whenever you have these key terms that come up, they should be buzzwords to think dysplasia and they're a feature of cancer. Okay. The others, as we could derive from that table that we were looking at, metaplasia is indeed reversible. Barrett's esophagus is a type of squamous metaplasia that we know. Metaplasia can be a physiological process, which is also true. And then again, we talked about how metaplasia is a transformation between one fully differentiated cell type to another. Okay. So dysplasia is a precursor to malignancy. And so if you have malignant type features within a question, it's going to be related to dysplasia rather than metaplasia. Okay. So let's move on to the next one. The following are the blood test results of an 86-year-old man. And those are the blood test results. You've got sodium of 128, potassium of 4, urea of 5, creatinine of 89, and a glucose of 13. What is the serum osmolality? Give you a little bit more time on this one. Okay, about a third of you have voted. Give it a little bit more time for those working on it. Okay, why don't we stop there? Sorry to those who are still working on it, but don't worry too much. Now, we've got, again, a smattering of different responses. Again, I think calculation-based type questions can be really tricky, especially if you can't really remember the exact calculation that you need to work it out, because clearly if you do, you just have to put the numbers in and you'll be fairly confident. Now, when I did the exam, there was only one calculation based question for me that I can remember anyway. And that was to work out the anion gap. I know this isn't to do with that, but I know someone else who had osmolality. So hence I've put this one in. So it's worth knowing osmolality, anion gap. There's so many different types of equations that you could spend time trying to learn. For example, mean arterial pressure, but given the fact that we've had these two types come up, I think it is worth just making sure, and it's just something, write it down in a notepad somewhere, and then just have a look at it, the day before your exam, just highlighting the key equations that you want to make, last minute revision. So the answer to this one is B, okay, it's 282. Now, the reason why is, again, if you Google, for example, the equation for plasma osmolality, you'll get probably quite a lot of different responses, especially if you plug in numbers to, for example, MD Calc, resources such as that. They use a more, a much more precise equation. Whereas I think it's acceptable in the MRCS to use the equation given in the textbooks, and that is 2 times, and sorry, I don't have a slide that has the equation on, maybe, no, sorry, apologies, but it is sodium plus potassium in brackets times by 2 plus urea plus glucose. Okay, and that will give you an approximation of the plasma osmolality, which is equivalent to your serum osmolality. Okay, and if you plug those numbers in, you'll get to 282. So the equation for serum osmolality for the exam purpose, 2 times in brackets sodium plus potassium, which here would be 128 plus 4, close bracket, plus urea, which is 5, plus glucose, which is 13. Okay. And again, you can jot that equation down. If it slips around, don't worry, just review it literally either on the morning of the exam or the day before. Okay. And I wouldn't stress too much about, all the different types of calculations that you think you may be asked. At the end of the day, it may be just one question of the whole exam. Okay, so we'll move on to this one. Which of the following options is the most appropriate for a patient with type 2 diabetes who is to undergo an elective day case inguinal hernia repair under general anesthesia? So, question a little bit more on perioperative care. Here to lists. Give you guys about 10 more seconds. Most of you have voted already. Okay, great. Let's stop there. Most of you, yeah, overwhelming majority for E for this one, and that would be correct, guys. So, yeah, a pretty straightforward question, this one, which obviously in terms of an elective case, particularly for type 2 diabetes, obviously there's now these days in terms of perioperative management and, your enhanced recovery guidelines as well, but essentially anyone coming in for a day surgery, ideally, it's not an absolute rule, ideally patients who are diabetic should be placed first on the list. Of course, you may have more than 2 diabetic patients with diabetes on the list, and that would change things, but as a general rule, place them first on the operating list if you can. And obviously in this stem of the question, it doesn't mention that there are more than one patient with diabetes, and so take it as it is in the question. They should be placed first on the operating list. Now, in the other options, obviously, type 2 diabetes patients, they're not totally dependent on insulin. Some maybe if they have really severe and they're on lots of insulin, but generally they don't need a sliding scale, especially for a day case. Clearly they shouldn't have any diabetes medications omitted, and Again, it shouldn't be pre or post-operatively, they should have their diabetes medication. And then again, with it's nil by mouth, it doesn't need to be these days, 6 hours prior to entirely. So although ideally, if it's first thing in the morning, it's preferable that they don't have any solid food for 6 hours. They can have some clear fluids up to about 2 hours prior. Okay. Now, I've put this slide in here because I think it's just quite a useful thing when you, and it's not an exhaustive list clearly because there's only 5 bullet points there, but when you get asked these type of questions where it's about where do you put a patient on a list, for example, these are some fairly simple rules to follow. And if it fits, it's likely going to be that. So like we've just discussed, diabetes patients early in the list, first if possible. Anyone who has a latex allergy, okay, they must go first on the list, okay, because what the theatre staff need to do is completely decontaminate the operating room from any form of latex. So they have to remove absolutely everything, and then they can't operate on another patient with latex for products in there for the possible, however low the risk may be of cross-contamination. Okay, so generally yeah, clean theatre with no latex ducts is one of those rules that you have. Children, again, operated early, the better, to minimize their distress, but clearly that could maybe be that's again, you're going to probably prioritize someone who's diabetes, insulin dependent patient over a child, for example, but aim to get them early. Major cancer operations such as anterior resections, again, they should be tried to be planned earlier on in the day because you really don't want to be cancelling cancer operations because maybe a list is running late, other administrative factors, that means that they can't get done. And I'm sure you're all aware that patients with infections, nowadays COVID is obviously relevant, they should be put at the end of the list if at all possible. If they can't, for whatever reason, if you've got a patient who's type 1 diabetic who also has an infection, you may have to compromise on one of them. Maybe they can just go on a sliding scale and go last at the list if it's a really busy, for example, CPOD list. However, it will need a deep, the room would need a deep clean after an operation. Okay, so moving on, we've got a 63-year-old man with type 1 diabetes and hypertension. If we can start the poll for this one. Lovely. So, yeah, 63-year-old man, type 1 diabetes and hypertension, undergoes anterior resection for rectal cancer. 4 days post, he describes faintness while walking to the toilet in the morning. His vital signs show blood pressure of 80/55, tachycardic at 125, and a respiratory rate of 24. His oxygen saturations are normal. Which of the following is the most appropriate immediate investigation? Okay. We'll give it about 5 to 10 seconds more. Most of you have voted now, actually, so we'll give it 5 seconds. Okay, great. So let's stop it there. Lovely. So 38% of you went for ECG, C. 25% of you went for ABG. So those were the two. Oh, actually, it was actually split between ABG and serum lactate. Okay. So these can be a bit tricky and ambiguous, to be honest with you, because you could really probably argue all day over which ones with different people. But I think, you know, for an exam, you need to try to follow kind of the reasonings that hopefully I can explain now. So the answer to this question would be C, is ECG. And the key reason why, I'm just going to have a look at the Q&A. Okay. So the main reason why for this ECG is the correct answer in this question is keywords in terms of faintness, and they have a circulatory compromise, particularly with that heart rate of 125. Although his respiration rates are up as well, his saturations are normal. So that may obviously being key, because we don't know a diagnosis for sure in this patient, just from the stem, it would suggest their lungs, because the saturations are normal, may not be the primary concern here. If you combine faintness with the tachycardia and with the low blood pressure, could be a variety of things. It could be an MI. You know, MIs post-op usually highest incidence is about, particularly if they have risk factors, is within 72 hours. So the timeline is fairly suited for that. Or it could be an arrhythmia, and they're hemodynamically unstable because of that arrhythmia, and hence they're feeling faint. So ECG is clinically relevant in this scenario, and it fits with the symptoms and signs that they've given you. ABG, again, it's a very reasonable option that you might want to do, but you're essentially, you know, the saturations are normal. And so although you're going to probably get a lot of good information from an ABG in regards to his clinical condition, it's probably not going to lead to a diagnosis in this case. Chest X-ray, no one voted for that. Again, good, because if you have best bedside tests before, for example, imaging, you want to be going probably into when it asks for you for an immediate investigation, you want to choose something that's probably bedside over imaging. If it was definitive investigation, obviously that would be different. Serum lactate you would get on an ABG anyway, so an ABG is more appropriate if one of A and B. ABG is going to be better because you're going to get a lactate reading from that. And so those two, given that they are quite, a lactate would be given from an ABG, also adds to the ambiguity, which may suggest to you that, is it something else? Okay. And then urine ketones, you know, it's not really going to, there's no urine. Although they're type 1 diabetic, you would probably do a urine dip and just check, but it would be very, very harsh for them to want that without a little bit more clinical information about the concern of, for example, DKA, okay? Or, for example, a missed dose of insulin, or, you know, no fluids, or missed something. They would give another clue added into it, okay? So that was a bit of a convoluted explanation. I hope it was clear, but just look at the concentrate and focus on what clinical signs they give you and how it fits with a test that would probably give you the most relevant information, and plus or minus, if at all possible, a diagnosis as well. Okay, let's go on to the next one. Which of the following is not true about the cell cycle? So which one of the following is not true about the cell cycle? Okay, half of you have voted at the moment. I'll give you about 15 seconds more. All right, let's stop there. Great. So 46 of you guys went for E, neurons remain in G1 phase of the cell cycle. And that's correct. I hated the cell cycle and studying the cell cycle. I didn't spend a lot of time on it, to be honest with you. I've seen it in different kind of past papers. Of course, you can't overly rely on past papers, that some of the resources that are out there. Fortunately for my exam, it didn't come up, but I do know a couple of others who sat at a different cohort and they did have one question on the cell cycle. So again, you know, guys, use your time smart and don't overly worry about learning in real great detail about these sort of things. But I've included it in there because there are just a couple of key points. I think if you try to remember from this, hopefully it'll put you in good stead. Okay, so E is the answer for this one. Now let's go to this because it's probably a bit easier with a diagram. In the cell cycle, you have two, essentially it's broken down into mitosis, which is your M phase, and then the rest, which is interphases, or they're all interphase. So G1, S, and G2, okay, make up your interphase. G0 is your resting phase in the cell cycle, okay? So like in cardiac cycle, when you had phase 0 as your depolarization, contrary to that, in the cell cycle, G0 is your resting phase. Okay, and G0, the resting phase, is essentially cell cycle arrest, where it doesn't do anything. It's not dividing, it's not making new proteinaceous material, it's just resting, and it's arrested. Okay, and that is where your kind of neurons that it refers to will sit, essentially. Okay, now, you know, to tell you too, I wouldn't know essentially the exact function of those neurons. You know, yeah, you don't need to know your basic science in that much detail, but just remember G0 is your resting phase where nothing happens, and terminated differentiated neurons lie there. Okay, and in this question, it says neurons remain in G1 phase of the cell cycle. So that can't be true because it's in G0. Okay. Just quickly glancing over the rest of the cell cycle, G1 is got a very high kind of synthetic activity. Okay, so this is where cellular contents are duplicated. Okay, it's making lots of proteins, etc., to be able to make the cell ready for duplication and eventually leading on to mitosis. Okay. And DNA synthesis is clearly, from the clue, synthesis is S phase, okay? That's where each of the chromosomes will essentially duplicate so that they can divide. And each cell that divides on from that, will have a full set of chromosomes within them. And then G2 follows on from S phase, like you see in the diagram, and essentially this is more of a proofreading phase. Okay, so G1 is more making things, G2 is more proofreading before you go ready into mitosis. Now, the other just one thing that isn't in the diagram that, you know, maybe you could try to remember is that G1 is the part of the cell cycle in which P53, which is obviously a key protein, tumor suppressor gene, which it affects the cell cycle. So P53 affects G1 within the cell cycle, okay? And again, B says G1 is under the influence of P53, which is true, so it can't be the answer. Okay. So moving on to the next one. Which of the following statements is correct regarding renal function? Okay, so thinking back to renal function, guys, which of the following is correct? Okay, we'll give it about 10 more seconds. About half of you have voted. Okay, let's stop it there. Great. So for this question, yeah, majority of you went for E, and E is the correct answer. Okay, so pre-existing renal disease is an important cause for post-operative renal dysfunction, which would make sense, right? And in this question, you know, if I were to go through this, E sounds reasonable, sounds right. So I'll just quickly go through the rest of the options to see whether I think they are also true or not. And you know, we know that A can't be correct because hopefully you'll know that it should be 0.5 ml per kilogram per hour for the urine output target, rather than 0.1, which is very little. In B, oliguria in the post-operative period is defined as a urine output of less than 25 ml per hour for 2 consecutive hours. I mean, you know, I've not heard of that really. And if you're going to really look for something, oliguria post-operatively should be less than 30 mils an hour for 4 consecutive hours. Okay, so the key is 30 mils per hour, and then for at least 2 hours is really short, actually. You know, furosemide should be started promptly in the post-operative period with low urine output for more than 3 hours. Well, you know, I'm sure some renal physicians may be a lot more bold, but essentially loop diuretics can also be, you know, potentially affect renal function too. And so when you've got a really severe AKI or renal insult, then, you know, you'd be well advised to try to hold that rather than starting it ASAP. But clearly it depends what is causing the renal failure. But again, C doesn't sound right. And then D, clearly a rise in serum creatinine isn't an early sign. Creatinine is quite a sensitive test that goes up fairly quickly without the patient going into impending renal failure. All right, so E is the correct answer. Let's move on to the next one. Which of the following is not true about insulin? So which is untrue regarding insulin? So think about the role that insulin has in the body. Okay, we'll give you about 10 seconds. Okay, we'll stop it there, guys. Good. So yeah, the majority of you went for D. It increases protein catabolism, i.e. that isn't true regarding the physiological role of insulin in the body. Okay, so D is the correct answer here. And if you look at this schematic on both sides, it essentially always think of insulin and glucagon as kind of opposites to each other in their role. Okay, obviously insulin produced by the beta cells and the pancreas, islets of Langerhans. Main role, and obviously most people will be know its effect on glucose. Okay, but also it's largely, think of it as an anabolic factor. So anabolic, everything to kind of do with breaking, to build up tissue. So it'll make it will help in fat oxidation and protein synthesis and storing glucose. Okay, whereas on the other end, you've got catabolism. And this is where obviously when you have an increased fasting, for example, you start breaking down glucose, breaking down your proteins for energy, breaking down fats for energy. Okay, so insulin is largely a anabolic hormone. Okay, and just remember, obviously, when we eat, insulin is stimulated to be released from the pancreas. And so when we have all of that food that we're ingesting, we're using that to build things up in our body. So insulin, an anabolic hormone, okay? And in regards to protein, it's obviously going to be protein anabolism rather than catabolism, okay? And the rest of the statements, if you go through them, are true, okay? But like we can see from the diagram. Okay. So let's move on from insulin onto this question. A 45-year-old patient undergoes a total pancreatectomy following severe necrotizing pancreatitis, which hadn't responded to conservative therapy. Which of the following is correct regarding the physiological effects of a total pancreatectomy on this patient? Okay, we'll give it another 10 seconds, 15 seconds or so. Votes starting to flood in now. Okay, a couple more seconds. Okay, let's stop it there. Great, lovely. So the answer to this one, which I think a lot of you did go for, is C. The loss of fat emulsification will result in malabsorption of vitamins A, C, D, and K. Now that can't be true because vitamin C is not fat soluble. So your fat soluble vitamins are A, D, E, and K. I don't know. When I was at med school, someone said cat in the attic. For some reason that just always stuck. So I remember fat soluble vitamins being A, D, E, and K. Because vitamin C isn't part of that, C cannot be true. Just working through some of the other options. Obviously, for this type of question, again, think about what the pancreas does for our body. And if you take away the pancreas completely, because this is a total pancreatectomy, think about what would result. And so clearly B, you know, they're likely to develop diabetes, probably likely as, you know, being, you know, underestimating, you know, they're definitely going to have a loss of insulin production. And so you're going to have that. Again, thinking about A, protein malnutrition and negative nitrogen balance ensures from a loss of proteolytic proenzymes. And again, you know, these, the pancreas, the exocrine function of it, producing your lipases, amylases, and different digestive enzymes is going to help to break down those protein stores from food to ingest. If you have an absence of that, you know, you're going to lose out on that part of your diet. And so you'll need supplementation. And then looking at D and E, there is malabsorption of iron. This is mainly because you get a loss of, the pancreas produces bicarbonates rich secretions under the hormone secretin. And so when you get a lot of that alkalinization of chyme coming out of the stomach and into the small intestines, that helps to digest kind of iron and calcium and phosphate. Okay. The exact mechanism of why the alkalinization is important for that, I'm not actually too clear on. So sorry, I don't have an explanation for that part. But it is that absence of bicarbonate-rich secretions from the pancreas into the intestines that will reduce the absorption of iron and calcium. And so you'll get iron deficiency anemia, increased risk, and then also without the calcium or reduced calcium absorption, you get risk of developing osteoporosis as well. Okay, so that's why D and E aren't correct in this question. Okay. And so this is a very simple kind of rudimental, really, schematic of the role of the pancreas. Obviously, we know endocrine functions, insulin, the major one that will result in the patient becoming diabetic, and then exocrine functions, which is the digestion of all of your foods. Okay, so let's move on to this question. An 80-year-old gentleman with multiple medical comorbidities undergoing excision of a basal cell carcinoma from his periorbital region under local anesthesia. Which of the following should be preferably stopped prior to surgery? Okay. Just over half of you have voted, so I'll give you about another 10 seconds. Okay, we'll stop it there. So, most of you went for B, aspirin. A few of you, almost a fifth of you, went for prednisolone. Okay, so B and prednisolone were the most popular answer, most going for aspirin. And aspirin would be the correct answer for this question. Okay, so by and large, antiplatelet therapies such as clopidogrel, aspirin, you'd want to stop them. So these days, some trusts have different rules, but for example, you want to stop it for about 7 days before your operation. Clearly, it depends on what type of operation you're having, but by and large, antiplatelets should be at least 5, if not 5 to 7 days of stopping before an operation. Okay, so that's the most preferable option. Now, obviously, the key, remember it's preferable. Okay, so but you may want to omit some of the other medications too. Clearly, you're not going to omit glucoside because diabetic patients really need their medications before an operation. Sometimes you may want to omit kind of antihypertensives or beta blockers, okay? But they don't generally need to be stopped for a day case kind of minor procedure, such as an excision of a basal cell carcinoma that can be done under local. And, you know, and that is something that could be reviewed and maybe just omitted on the day if you really needed to. But typically you don't need to omit those sort of medications. Prednisolone is an interesting one. A few of you went for now. And I think this is the probably, other than knowing that antiplatelet agents need to be stopped 5 to 7 days prior to an operation, it's important to know about steroids perioperatively. Now, the biggest reason why you don't stop steroids, and actually when you're going, the body's going under stress, you want to actually double up sometimes doubling up your doses of steroids. And generally these patients who are on long-term steroids, during their preoperative assessment, they'll either have guidelines that they need to adhere to. For example, they would need X amount of hydrocortisone IV on induction of anesthesia, or they'll have their endocrinologist who will advise the exact doses that they need to go on. Typically patients will have IV doses of steroids and at induction of the operation, and then post-operatively until they can eat and drink again, and then they'll be weaned down back onto their normal oral dose. All right, and the biggest reason why is because withdrawal of corticosteroids or stopping them may lead to an Addisonian crisis. Okay, patient going to shock, oliguria, confusion, and potentially a life-threatening condition. Okay, so remember, prednisolone or any form of steroids shouldn't be stopped for an operation. Okay, so let's go on to the next one. A 60-year-old man suffers a moderate closed head injury, and they're brought into the resuscitation room with a GCS of 10. Which of the following measures will not be useful in maintaining cerebral perfusion and oxygen delivery? Okay. A third of you have voted, so I'll give you about another maybe 15 seconds. Yeah, they're starting to flood in now. All right, let's stop there for this one. Great. Okay, so varying degrees of answers. Split between A and E, 15 degrees head up tilt or placement of an intraventricular catheter. Now, we're asked for someone with a low GCS, they're intubated, or we'll know from one of the answers that they're likely to be going in towards intubation. Which of the following isn't useful, okay, in maintaining cerebral perfusion and delivering oxygen? Okay, the answer to this actually was D, steroids, and about a fifth of you went for this choice of those who voted. Reason being, first of all, steroids, in its role of head trauma, it has none. The only occasions where you would initiate steroids. Maybe you've seen it in clinical practice where you do a CT image, there's an incidental finding of what looks like a mass with fat stranding around it or something on a CT scan. There's inflammation, an inflammatory process going on, and hence you want to reduce that inflammatory reaction, therefore giving steroids. So those are the occasions where you give steroids, or for example, in some of the more rarer intracranial kind of infiltrates or your meningitis type picture, you may get steroids, okay? But in just pure head trauma, steroids don't have a role, okay? And again, further on to that, steroids also don't have a role in any way of measure, reducing cerebral perfusion pressure or increasing cerebral pressure, or clearly it doesn't have an effect on oxygen delivery. Okay, so just looking at the others. So A, 15 degrees head up tilt. Okay, that is good to nurse patients in that manner because that reduces venous congestion in your neck and head. So theoretically would potentially reduce cerebral pressure, because remember the goal here is to prevent rising intracranial pressure that may lead to herniation. Because if a closed head injury has happened and you generally the sequelae is a bleed into the brain, either epidural or subdural hematoma, with that Monroe-Kelly doctrine, which is an unforgiving closed space, you want to avoid increasing that intracranial pressure that would then lead to herniation. Okay, so reduce venous congestion to try to reduce the volume in the head or the cranium. Then B, mechanical ventilation is generally always done for these type of patients, because then you can control oxygenation, which is a key point, and then also carbon dioxide level, which is a vasodilatory, fairly potent vasodilator in the brain. That's going to increase your cerebral pressure, hence ICP. So you want to increase it so that they ventilate out their CO2 to prevent buildup of that. Mannitol, again, is very good. It's an osmotic diuretic, and so it can help to reduce the volume of cerebral blood flow, which is clearly a good thing for this type of patient. And the reason why E is also useful, and so can't be the correct answer here, is that you can measure the ICP through it, and so you can keep monitoring it. So that will be helpful in maintaining cerebral perfusion. Okay, so although it's not necessarily it's not a therapeutic intervention, it can give you a good, precise measurement of the ICP. Okay, and then off the back of that, obviously, you can do some form of drainage. So we'll carry on a little bit longer. I know the session was meant to be an hour, but we've got a few more questions, and I think generally from the feedback that we've been getting, more questions is a good thing. A 60-year-old man is found to have microcytic anemia on his preoperative assessment. Which of the following statements regarding the physiology of anemia is false? Give you a little bit of time for this one. Quarter of you have voted, so I'll give you a bit more time just to give you guys a chance to answer. Okay. We'll stop it there for now. I know. Okay. It's a bit of a tricky question, especially with it being a little bit wordy in its answers. But and it was a varied response in terms of how you guys answered too. There wasn't really a majority that stood out. The answer to this question is C. Anemia has no effect on the oxygen carrying capacity of the blood. All right. So why is that? Well, remember that something that's useful to try to think of when it's anemia, try to remember that it's the quantity, not the quality of the amount of hemoglobin, in your bloodstream that is affected. Okay, so the actual binding capacity of the hemoglobin that is present, although it's a reduced quantity, will still have its full function. Okay, so anemia has no effect on oxygen dissolved in the blood is true because the hemoglobin that is still present will still be able to dissolve the oxygen as well as the saturation. So often clinically, obviously, when you have an anemic patient, it's absolutely rare, or you don't really see it where their saturations are affected from that. All right, so A and B can't be true. C is correct because, like I've just said, anemia affects the quantity rather than quality of the oxygen carrying capacity. Its function with oxygen, dissolving oxygen, carrying it around in the body. But remember that you've got your dissociation curve, that sigmoid dissociation curve. And now when you have reduced hemoglobin in the body going round, the carrying capacity of the hemoglobin for oxygen is also slightly reduced. Okay, and hence there's going to be a tendency to prevent release of oxygen into end tissues because of that relative reduced absolute number of hemoglobin. All right, so the body thinks that there's less hemoglobin, it's less oxygen going around than usual, so it's going to try to hold on to that. Okay, and so you'll get less oxygen being released from binding. All right, and it's a similar, so having no effect is not true in C. D, it's a similar theme of what I've just been talking about. It reduces the amount of oxygen released from binding for the same drop in venous PO2. Now, that statement where it says same drop in venous, PO2, I wouldn't have known that. But obviously, from what I've just been saying from that sigmoid curve, you do know that it reduces the amount of oxygen released from binding. Okay. E, rapidly deteriorating clinical indices are often noted when HB levels acutely fall below 7. And, that can be true. If you have an acute drop, to under 7, that usually means you've had a pretty big bleed from a patient who has a normal HB. So they would have symptoms, or, they're more likely to have symptoms of anemia because of that rapid drop, and the body hasn't had time to adjust to those new levels of anemia. So you get shortness of breath, faintness, lethargy. Okay, so we'll go to the next one. 75-kilogram man is undergoing an elective inguinal hernia repair. What is the correct maximum dose of 0.5 bupivacaine with adrenaline that can be given? So it's bupivacaine with adrenaline in this question. What's the safe maximum dose that you can draw up so that you can give a little bit of local anesthetic to this patient in the wound, for example? Also, I'm very sorry for in the poll, just take it as it's corresponded in the question rather than those absolute mil values, actually. Sorry about that. So answer it in mgs per kg rather than those values. Okay, I'll give you about 10 to 15 seconds for okay, why don't we stop it there? Okay, so sorry about the poll where giving the absolute values, but for this question, it would be looking at just the mgs per kg values. The answer to this would be, the answer to this would be C, 3 mgs per kg. All right. Just you guys, you'll need to learn essentially the doses, safe doses. Learn it for lidocaine and bupivacaine because they're the two that generally come up in the exam if they do. The maximum dose for bupivacaine with adrenaline, okay, is 3 milligrams per kilogram. Without adrenaline, so let me actually just go to the slide that shows it. So this is a slide that's useful for you guys. Bupivacaine without adrenaline, 2 mg per kg. With adrenaline, and generally with adrenaline, you can give a safer dose because the main reason being you get vasoconstriction from adrenaline, and so less of the local anesthetic that you're using will be immediately absorbed by the body and into the systemic circulation. It will infiltrate a little bit more slowly because of that vasoconstriction. And again, for lidocaine, without adrenaline, it's 3 mg per kg. With adrenaline, 7 mg per kg. Okay. And I, for the exam, just learned those absolute values. I didn't, sometimes in the STEM, if it says 0.5% or if it's 2.25%, for example, in terms of max doses, I still just use these absolute values. Okay. Let's move on to this question. Okay, so just got a couple more questions left, guys. Sorry about the time, but I think it'll be good to go through them. Which of the following is not true about the control of respiration? So, thinking about what affects the control of regulation and respiration, sorry. Okay, I'll give it another 10 seconds on this one. All right, let's stop it there. Lovely. Okay, so the majority in this question was answer D, which is correct. Chemoreceptors respond to a rise in pH. Okay, so just looking through this, because it is, I think it can be quite a difficult one if you get caught up in, the pneumotaxic center, the apneustic center, for example. But if you look at some of the options, and we can work through them, all right, let's start with just why D isn't true. And for those of you guessed right, in terms of your reasoning, it probably were that the chemoreceptors, all right, the peripheral chemoreceptors anyway, they respond to a decrease in pH rather than an increase in pH. That being because, for example, carbon dioxide, when you think about your acid-base balance, carbon dioxide primarily as a driver of respiratory acid-base, if it is increased, i.e. someone's retaining carbon dioxide, it generally will make you acidotic. Now, if you have a low pH, okay, which means a greater acidity level that corresponds to a high PCO2, you would want the respiratory centers to kick in, so you hyperventilate all of that CO2 out, all right? So that is the relationship, and that is why D isn't correct. Okay, in terms of the other parts of that question, if you can know that well and clear and have clarity in your mind about that relationship with PCO2 and pH in regards to these chemoreceptors, and then, you know, you would be able to at least deduct kind of these type of things about the chemoreceptors, because I think that is something that makes sense, easy to understand. And also peripheral chemoreceptors are found in the carotid body. Okay. Now, in regards to the pneumotaxic center, medullary, obviously the medullary respiratory center is the main one within the pons medulla, within your different types of respiratory centers or nuclei that are present, whereby it controls inspiration and expiration, or the rhythm of breathing. Okay. The pneumotaxic center, it's not clearly put here, but is located in the upper pons, all right? And it controls how long we breathe in, essentially, okay? The apneustic center is present also in the pons, lower down, and it also can prolong the inspiratory phase, all right? So apneustic and pneumotaxic centers in the pons can control essentially your inspiratory phase in its duration, and how long you are breathing in for. Okay, so those are the main things here. So apneustic center in the lower pons, and both of them have an impact on inspiration. Okay, and then we know that the medullary also controls the rhythm of breathing. Okay. Again, it's probably something I wouldn't get too stressed about or worry too much about exactly where these centers are, pneumotaxic or apneustic, in their exact role. I never went that deep into revising and studying about those sort of things. I just tried to remember central control and chemoreceptors, where the peripheral chemoreceptors are located, because you have different types of chemoreceptors, like your baroreceptors, for example. So know where they're located and what they respond to. And then generally, if you know that, you'll probably be able to answer these types of questions, because that's what they're really focusing on. So the last question we'll do today: which of the following hormones is not produced by the anterior pituitary gland? So last one of the day. Okay, give it about 5 more seconds on this one. and we'll stop there. Okay. So we have a split actually between B and E, the antidiuretic hormone and prolactin. And the answer to this, i.e., which is essentially out of these produced by the posterior because it's not the anterior, is B. It's the antidiuretic hormone, ADH. All right. So again, you know, this type of question when it comes up, once you know it, it will be easy marks. You'll read the question. It's a short stem. It's just a few answers. Bang, done, move on, and then that will help with your time management within the exam. So it's quite a common thing. Pituitary gland stuff. Easy marks if you know it. Your anterior hormones, and the two main ones from your posterior is your oxytocin and ADH. This isn't actually a great diagram because you've just got loads of arrows coming from both pituitary glands, but remember it's oxytocin and ADH that come off the posterior aspect of the pituitary gland, okay, and all the rest anteriorly. All right, so again, I hope that was useful. I know within the time constraints we have, it's, you know, ideally, we'd like to go through as many questions as we can, but we try to pick out the ones that we think are helpful, hopefully consolidate some of the things that you've been learning, okay, and a varied kind of level of questions that in difficulty that can be asked within the exam, okay. So there haven't been any other questions in the chat. I know someone said, can we go quickly over the first three questions at the end? But does anyone have any questions in regards to any of the questions or just any general things? If not, okay, the next session will be on Monday evening. It's the end of the bank holiday, but if you're keen to return for some more, you know, chance to drill some questions, the session will be on Monday evening. It'll be on trauma and orthopedics. So trauma is a huge topic that can be really high yield questions in which you can really you know, gather your marks because it is asked all the time. Quite a fair volume of the, you know, proportion of questions asked will be on trauma stuff, a little bit on orthopedics too, and I'll include those. But yeah, trauma is a massive topic on this. Knowing your kind of ATLS type knowledge and background on that will be important for your Part A exam. So that's what we'll cover on the 18th. This is the QR code for this session, guys. If you know, we've been looking at the feedback and you know, if you've been attending some of the previous ones, thank you so much for providing that feedback. It's really helpful in trying to, you know, make small changes here and now. You know, we are limited in what we can do, but we try to cater as much as we can. There's also a link on the chat if the QR code isn't working for the feedback. If you could just spend a couple of minutes filling that in, that would be great. If there aren't any other questions, I will just quickly flick back to the first three questions. We don't have the poll to go through, I'm afraid, for the person who put this up. But yeah, feel free, for those of you who have filled out the feedback, thank you. And we'll see you next time, hopefully, and have a great evening.